Well, thank you, Victor. Thanks for having me over. It's a pleasure to be here in the morning. Well, nothing to disclose. So, the reason for me being here is that I started using this SubLiminal, this kind of threshold technology about 14 months ago. And by now I had some few basic, serious questions you may be having right now. Maybe some of you are considering seriously to use this technology. Maybe some of you already have recently and had them. So I have divided them in just in let's call them two basic chapters. First, how do I do it? Because it's difficult and it's something special in the technique. And of course, what is it good for? Which patients will benefit from it? How will it improve my daily practice? So how is it done? Well, for anybody minimally used to perform macular laser, there is no such a great difference. It's relatively unchanged. The only thing, the thing that changes the concept. Here, as Dr. Chong said earlier, we are not shooting that aneurysm, we are not burning that leaking point. Here we are stimulating RPE cells in order to work for us. So they become molecular factories with therapeutic effect. So since one cell produces very few protein, we need to treat a large area to treat a lot of cells. And this area we are treating to make sure we are treating the whole of it, so treat it densely. Power, I found it to be secondary to these two main things. You can start at 50% saturation power. If you're not too sure at the beginning, you can start even lower and raise posteriorly if necessary. Then SubLiminal technology comes equipped with a couple of features that help you achieve these two important milestones, which are surface area and density. First one, and the patterns. Let's see this example, this extra foveal edema. You want to treat it. Laser provides you with two kinds of patterns, square, macular grid are your choice. You can customize them, make them wider, longer, whatever. It's an aiming laser. You just place it, use a reference like a blood vessel or a microaneurysm, and start treating. You will see the spots start to be delivered one after the other, and if for whatever the reason you have to stop, patient moves, doesn't matter, you just stop the treatment, then replace the square, replace the grid, and the resume function will restart the treatment right at the point where it was stopped. So making sure you achieve that density we were talking about. That's pretty much it about technique. What is it good for? With examples. I wouldn't get into the frontiers of research. I will talk about CSCR and diabetic macular edema. Well, about CSCR, I don't know if it's beginner's luck or what this been a game changer for my routine practice. I don't have access to PDT. Before, I had to send my patients to my reference center 90 kilometers away, so it's been a game changer for them too. I've obtained outstanding results, improvement in 7 out of 8 cases, and most of them with total resolution. One case. This is at this moment an extra foveal supraretinal fluid which fluctuated. Sometimes it invaded the fovea, sometimes it receded, but the patient was permanently with that fluctuating scotoma for 5 months. So we did it around here in the pupillomacular bundle. This corresponds to the area of leak in the angiography. 3 months later, we have nice resolution. I like to use the thickness map to evaluate the response. The slides can be tricky, but the thickness map doesn't lie. It shows the generalized staining. 3 months later, everything remains still. This is an after photo. So find the spots if you can. There were about 200 spots released here in the papillomacular bundle. They don't seem to be visible. They don't seem to be visible on the autofluorescence either. Maybe just a little bit of the 2 or 3 titrate spots in the periphery. One more case. This came to me after 2 failed sessions of PDT. Vision 0.6. We treated. 6 weeks later, supraretinal fluid didn't improve that much, but the cystic component, the retinal component resolved, so we just waited to a complete resolution. 6 weeks later, with vision at 0.9. I'm going to say this is the patient's only good eye, the only one lost to a poorly evolved CSCR years ago. One more case. This is the eye of a general practitioner in my area. He had been around for years. All sorts of treatments, also all sorts of diagnosis. You can see there's quite a big version of the external retina. One session, one session we achieve resolutions of retinal fluid. Of course, vision doesn't improve. Look at how the outer retina is, but at least the scotoma remains. Paracentral scotoma remains stabilized. Just one more case. Some never resolve at 6, some of them take a little bit longer. Here it has resolved foveally. There is still a little bit of fluid superior, but I'm confident it will resolve with a further treatment. I will not get into the specifications of data, just use angiography as a guide. Although I have found autofluorescence to be quite reliable too, at least in not too chronic cases with not too bizarre autofluorescence imaging. 5% of the cycle is enough. Treat, of course, as a large area, center the leak spot, and avoid treating the fovea. It's not necessary. Fovea is very small, so if you do not treat those cells, but treat a near area large enough, therapeutic effect should extend to the fovea, and you will sleep better at night. Evaluate at 6 and 12 weeks, and evaluate yourself, and check out the fluorescence. If you see the spots, just reduce your power. DME is way more complicated disease because it has a wider variety of manifestations in patients. I have found SubLiminal to be especially helpful in the inflammatory exudative, or we could call it pathogenic edema, without a relevant ischemia. That leaves us with 3 scenarios. We'll go one by one with examples. First, maybe the less controversial, the clinical significance of extrafoveal edema. Still today, many practitioners will treat this with conventional laser. Very mild burns in order to reduce this edema, which is slowly creeping, sending exudation towards the fovea, which will be within SubLiminal. In diabetes, you always have a slower response, but it's usually more durable. If I don't say the contrary, the images are 1 to 12 weeks after the opera. So 12 response, 24 still a little bit more with an untouched RPE. This is a clinical significant, nearly foveal edema. It will be maybe a harder decision to use conventional laser here. We laser this area and a little bit of the surroundings. As I stated before, we need a lot of cells to work for us. 12 weeks later, we have a nice thinning, no visible scars, resolution of the fluid. The exudation always takes longer. And there was some kind of metabolic discontrol. 12 weeks later, we had a little recurrence, but also in the periphery. Here you can see the improvement, vascular abnormalities, and the number and density of the exudates. This is week 0, week 24. Now, second scenario, when the fovea is involved, that vision is good, and good vision usually means central thickness under 400. Some clinicians would inject. I mean, there is cysts in the fovea, so let inject. Some would wait, maybe improve metabolic control. Very few would use conventional laser here within the 500 microns of the fovea. Here, SubLiminal provides us with an extra tool. As I said earlier, I don't treat the fovea, but I go quite near it. Nice improvement after 3 weeks, thinning of the retina. Good vision is which past 0.8 is preserved. One more case, very similar. Finally, third scenario, combined treatment, consolidation treatment. When you have a fovea deeply involved, deeply bathed in this inflammatory soup, you don't want to perform a laser and wait for 3 months for it to work, because as we know, the longer the photoreceptors spend bathed in that fluid, the poorer is the visual recovery. So I treat it with intravitreal injection, steroids, anti-VEGF, depending on the case. We obtain a nice response. We have turned this case 3 scenario into a case 1 scenario, which we now can consolidate with laser and obtain a nice, long-lasting result with just 1 injection and 1 laser session. One more case, also fovea involved. Nice response to intravitreal and nice consolidation. So, treatment guidelines. I will not get either here into technical detail. Just use the thickness map not only to evaluate but also to guide you. Treat the area or areas that are thickened at the center and surroundings. Avoid treating the forehead, not necessary, and patience. Evaluate at 12 weeks. And check yourself. And that will be everything. At final remarks, of course, as always, when you're starting, follow safety recommendations until you gain experience and confidence. Surface area and density are the cornerstone. This is the idea. We have to change. Patience. Laser is at least relatively slow compared to what we're used to with intravitreal. And of course, it's more surgical than medical retina. This is an interventionist procedure, so audit your results and audit yourself. In every case, register parameters, register any abnormalities you notice, so you can see if they have any influence in your outcome or not. Autofluorescence is very useful. And with this, you should be all right and having great results in no time. Thank you.